Okay, so for pneumonia, here's an overview of what we have. We have the introduction, causative organisms. We have the stages of pneumonia, more specifically for lobar pneumonia, risk factors. We have the clinical features. We have the sample history. We have the general exam bit of it, relevant systemic exam, which in this case is RESP. We have investigations, management, and a sample Viva question at the end. So pneumonia, what is pneumonia? Pneumonia is basically an infection of the lung, interstitium, the alveolar space. It's an acute infection, lung parenchyma, in other words. So the different types, and they are grouped according to different things like setting, different factors like setting. Um, Others are grouped by presentation of the pneumonia. Others are grouped by location of this infection. So for the types, according to setting, we have community-acquired pneumonia. This is very common. We have hospital-acquired pneumonia. It's less common, but you'll come across it. And then we have healthcare-associated and aspirational pneumonia. So for community-acquired pneumonia, this is pneumonia that's acquired outside of a hospital setting. This is These are people who come in with the pneumonia already. For the hospital-acquired pneumonia, this is pneumonia that people acquire in the hospital. So there's also a cutoff for this. It's usually 48 hours. So patient must have spent 48 hours before you can, classify this as a hospital-acquired pneumonia. So between after 48 hours of admission and they begin presenting with the pneumonia, then you can safely assume it's a hospital. For the healthcare-associated pneumonia, this is pneumonia that is acquired in healthcare, settings, sort of setting like hospices, or um, there are also some transfusion centers that are not necessarily hospitals, but patients could acquire pneumonia from there. So the patient has a history of frequenting those types of places, then it's a healthcare associated, sorry, pneumonia. So we also have the aspirational pneumonia. It's not really a setting, more of a mode. But people who aspire things, when you ingest something, it's supposed to go down your esophagus. But assuming something happens, something goes wrong, and then it goes the wrong way into the trachea, finds its way into the lung parenchyma, and with it, it's carrying, microorganisms, microbes, then it's gonna cause trouble, and then you get an aspirational pneumonia. So from the name, you just aspirate, food or drink. A lot of the time, it's alcoholics who get this type of pneumonia, because also when they tend to puke, when they overdrink and then puke, sometimes that vomitus is aspirated. So types, according to the presentation, we have typical and atypical. So typical pneumonia presents in a textbook manner, and atypical pneumonia presents in a sort of weird. So the typical pneumonia may present with chest pain, the fever, um, productive cough, what else? Things like that. And then atypical might present with a dry cough, which is something we don't expect with a pneumonia. It might present maybe without a fever, which is also something we don't expect in a pneumonia. So you get the gist. Then there's types of pneumonia according to the location. So the location of the infection. Infection could be in the bronchus, okay? It could also be in the lung lobes, or it could be in the interstitium. So this is that space between the alveoli. Now, for the causative organisms, we have two groups. We have causative organisms for typical pneumonia, and we have causative organisms for atypical pneumonia. So here are some of the causative organisms for the typical pneumonia. We have strep pneumonia, we have Staph aureus, which is very common in the hospital setting. So if the person has a hospital-acquired pneumonia, it's more likely a Staph aureus. We also have Klebsiella pneumoniae. We have Haemophilus influenzae. These are more community-acquired. Under atypical, some of the causative organisms we have include Mycoplasma pneumonia, we have Legionella pneumophila, and coronavirus and cytomegalovirus virus. So these cause a type of pneumonia that presents atypically, with a dry cough, give or take a fever, give or take chest pain. So here we have stages of pneumonia. So there's about 4 stages. So we have congestion, we have red hepatization, we have gray hepatization, and then we have the resolution. So the congestion phase, there's a lot of WBCs, and then they sort of make alveoli a lot more permeable, and then now there's fluid congestion, exudates, mucus and whatnot, as you can see illustrated here. Then the red hepatization phase, there's a lot of RBCs that come into the mix. Thus gives the lung, the lobe of the lung a very more red than usual appearance. Then the gray hepatization, now that the RBCs have died off, um, they're being broken down, it sort of turns gray, like a wound scab, it sort of turns gray. And then for the resolution phase, now everything is calm. So all that infectious, purulent material now is being cleaned out. So for the risk factors for pneumonia, this is something that must come out in your history. Um, for all sorts of illnesses, you must bring out the risk factors so as to try and paint the picture of why this patient is high risk of this. So some of the risk factors include pre-existing cardiorespiratory conditions. These include things like heart failure. Heart failure being CVS also has implications in resp. Things like chronic obstructive pulmonary disease, things like asthma. Other risk factors include immunosuppression. So any sort of illness that may suppress the immune system, like HIV and AIDS, any sort form of malnutrition, because proteins are very essential in production of antibodies. Um, so if one is malnourished, not getting enough protein, then there's also going to be a problem with antibody production. Things like DM also suppress the immune system. Smoking, drinking, overcrowding, surgical procedures. So these are questions you must ask the patient. You must ask if they're HIV positive. You must ask about the nutrition. You can make a quick assessment just by looking at them, but please try to probe a bit further. Ask them what, the 24-hour diet looks like, whether they're getting enough proteins or not. Ask if they have diabetes. Ask about smoking. If they do, what are the smoking patterns? How often do they smoke? There's a whole pack years. So also calculate that and bring that out in your history. When it comes to drinking, try to probe what exactly does this patient drink? How much do they drink and how often? You also should quantify this in units, usually units per week. There's also cutoffs for this. There's cutoffs for females. There's also cutoff for males. They're unique. For the females, I think it's 8 or is it 10 units per week. That's the recommended cutoff. Anything more than that, then it's gonna bring problems. For males, I think it's 10 to 12, 14, much. Just go confirm them. Overcrowding is also a huge risk factor. Pneumonia is known as a disease of the bachelors because male bachelors, I mean bachelors obviously are male, but males who are bachelors tend to live in very deplorable living conditions with overcrowding. Sometimes you might not get a male patient with pneumonia, you might find a female patient. Um, Human, she's a high school student and they have overcrowded dormitories, then that raises eyebrows. Could be a pneumonia. Surgical procedures. So surgical procedures like dental procedures, more specifically, tooth extractions. There might be a bit of contamination. makes its microbes make their way down the trachea and then cause problems. So for the clinical features, according to the types of pneumonia, according to what is the presentation, we have the typical pneumonias and then we have the atypical pneumonia. So clinical features for typical, we have a productive cough, we have pleuritic chest pain, we have dyspnea, we have tachycardia, we have fevers, and we have chills. So this is the textbook presentation of a pneumonia. Atypical, now this is a bit, it's different from what we expect. Patient might present with a non-productive cough, which, if you're not careful, could confuse you and probably lead you away from the right diagnosis of a pneumonia. The patient could also present with dyspnea. Patient could present with headaches, which we don't really expect. Uh, which we don't really expect. Or they could present with a sore throat and myalgia. So it's just general body aches that are a bit dull, fatigue, get the gist. Uh-huh. So here I have a sample history. I'll ask one of you take us through this page, just as we have been doing. Debbie,
Yes,
could you,
okay.
could you,
So I just read it as it is.
yeah, just read it as it is, and then once you're done, we can accept this page.
Okay, so biodata. DO is a 45-year-old male. He resides in Bungoma. He has been working as a farmer for the past 20 years. He was admitted, so let's say probably 2 days ago. Um, so the chief complaint, sorry, is this a chief complaint? Yeah, presenting complaint. A 3-day history of cough, chest pain, and shortness of breath. Then in the HPI, DO was stable until 5 days ago when he began to cough and experience chest pain and shortness of breath. Initially, the cough was dry and non-productive, approximately one bout every 2 hours throughout the day. But over the next 24 hours, it began to produce a yellowish mucoid sputum, approximately 5 to 10 mils in volume, with 5 bouts every 2 hours. The cough was accompanied by a hotness of body and chill. DO tried taking over-the-counter medication, more specifically acetaminophen to control the hotness of body, but it did not provide significant relief. That's it. Savimbi, is that it, or I need to continue with something?
Debbie, hey, sorry, I didn't realize I was muted. So thank you for reading. Although I just need to point out something small. When you read the history, when you're presenting it, please don't like mention you
Okay.
are like I'm reading from the bio data, I'm reading from the presenting complaint, reading from the HPI,
Okay.
just go with it.
All right.
Yeah, but thank you.
Okay.
So here in the bio data we have initials or assume it's the name of the patient. We have the age, we have the sex, we have where they reside, we have the occupation and how long they've been doing it. Because a few respiratory issues might be occupational diseases. So we want to know how long this person has been doing and what exactly their job entails. And then we also have when this patient was admitted X days ago. They presented with a 3-day history of cough, chest pain, and shortness of breath. So there's a presenting complaints, and there's also a timeline for these presenting complaints. It was almost around the same time, which was 3 days ago. So this patient was stable until 5 days ago. And then the patient began to experience things like cough, chest pain, and shortness of breath. So shortness of breath is the more preferred um, term to use in respiratory difficulty in breathing. It's more preferred in CVS. Using them interchangeably is not really a sin. Just try to, get used to shortness of breath and respiratory. So about a cough, we want to know whether it was productive or non-productive. And in this case, it was dry and unproductive. And then we also want to know how many bouts. So this tells us how frequent it is. It also paints a picture of progression if you give frequency of the cough in the early stages and in the later stages. So here the patient had one bout every 2 hours. So this is coughing 2 hours once, 2 hours. And then it's throughout the day, so there's no specific time. Some conditions have symptoms that worsen at particular times of the day, like asthma. It's particularly worse in the evenings and in the mornings. So by being told this, then you can assume this isn't an asthma. So this patient then began to produce a yellowish mucoid sputum. Now it's beginning to present more like a typical pneumonia, and approximately 5 to 10 ml in volume, with 5 bouts every 2 hours. So now you see like the cough has increased in frequency, so it tells you that it's progressively worsening. It's worsening, sorry. And then now the symptom is accompanied by hotness of body. So we don't say fever, we opt for hotness of body. It's more descriptive because a fever could be low temperatures or it could be high temperatures. You say hotness of body. It's a more accepted term. And chills. Now, also here, DO tried taking over the counter medication, more specifically as acetaminophen for the hotness of body. But it's, so from the mnemonic operates, we have onset of this, we have progression of this, we have he was alleviating symptoms, alleviating factors. In this case, is acetaminophen, but it did not help. We also have, sorry, I confused. But for the timing throughout the day, associated symptoms, we have hotness of body, and then the severity, it's from the bouts, the production of symptoms, as you can see. So this, basically everything on operates is touched. Into the next page. Um, I'll ask Noor, could you please unmute and take us through this page? Noor, we cannot hear you. If you're experiencing any difficulty, it's fine. I can ask someone else to take this. Or do you still want to go ahead? Unfortunately, we still cannot hear you. No, it's fine. I can just ask someone else to take us through. W, please unmute and take us through this page.
Dio reported a certain onset chest pain localized in his right lower chest area. He described it as sharp. It was constant over the next 3 days and worsened by deep breathing and coughing. He rated the pain a 4 to 6 out of 10 in severity. Painkillers gave him some mild relief. He did not experience any radiation of the pain to his back, arms, or legs. Over the past 2 days, he noticed shortness of breath, even at rest. DO also experienced acute onset difficulty in breathing that hindered him from walking at his own pace, MMRC dyspnea grade 2. It was not progressive. Resting alleviated this. DO confirms being an active smoker with 22 pack years and an alcohol user averaging about 16 units per week. He takes mostly illicit brews and strong spirits. He also handles multiple pesticides and insecticides, which are irritating to his nose. He mostly uses them to spray his crops every 2 months, the last time being less than a month ago. He doesn't use a proper mask as he can't afford one. Rather, he uses a close to cover up his mouth and nose, which sometimes is ineffective. He denied experiencing any trauma to the legs, undergoing any surgery procedures, or prolonged duration of immobility. Dio denied any weight loss or previous TB drug therapy. Dio has no history of itchy eyes or skin, no history of orthopnea or PND, or leg swelling. Dio is also a IBD negative, no history of alcohol use. Since arrival, he's been put on supplementary oxygen, had blood samples taken, a chest X-ray done, and has received antipyretics and antibiotics. He is relatively well and is awaiting results.
Thank you, W. So while typing this, I made a few errors. This is supposed to be a piece of cloth, and this no history of alcohol use is not. Let me just quickly correct this. Okay. Okay. Thank you, W. So for the chest pain, we use Socrates for pain. What we need to have is sight, which is the right lower chest area. The onset, sudden. Character, it's sharp. Yeah, yeah, it's sharp. We also need to have radiation. So according to this, it's non-radiating. There was no radiation to the back, arms, or legs. We also need to have any associated symptoms, but there was none in this case. Timing of it worsened by breathing and coughing. Alleviating factors, in this case, he doesn't have any, and then the severity. So for pain, you ask the patient to rate it on a scale of 1 to 10, 1 being little pain and 10 being unbearable pain. So this paragraph captures all of that. So on to the next paragraph. The acute onset difficulty in breathing, or rather shortness of breath. This patient describes it as something that hindered him from walking at his own pace. If you look at the MMRC dyspnea gradings, this falls under grade 2. Patient is unable to keep up with contemporaries on a flat surface. And then the shortness of breath was non-progressive and resting alleviated this. Now comes the risk factors, the etiologies, what could have caused this. So this patient is an active smoker with 22 pack years, which is quite a lot. This patient also he also is an alcohol user, and this patient averages about 16 units per week, which is above the accepted limit for male. Then we have what this patient takes mostly, illicit brews and strong spirits. So you can just imagine how strong this is. And then this patient, who is a farmer, also handles multiple pesticides and insecticides, which are very irritating. So the positive history of chemical irritants. This patient uses them to spray the crops, and then this patient does them every 2 months or so. Is quite a lot. Then last time being less than a month ago. This patient also doesn't use proper protective wear, proper mask, but the patient opts to use a piece of clothing or a piece of cloth, which is not exactly what's recommended. So you can imagine how much this patient inhales from time to time. So these are the risk factors. So you can imagine how the protective mechanisms, the trachea, um, are affected. So you have smoking, you have alcohol use, you have use of irritants, chemical irritants, and improper covering up. So you can imagine the protective mechanisms of the trachea are affected, and then microbes just find their way down. They have a much easier time finding their way, causing trouble. Now comes the important negatives. So in this next part, this is ruling out of any other condition that may present in a similar way. So there are a few questions that you can ask. You can ask the patient if they've experienced any trauma to the legs, whether they've undergone a recent surgical procedure, or if they've been confined to the bed for prolonged periods of time. Pulmonary embolism is a result of any of these things. Also, malignancy. So you can insert the B symptoms or the B questions or constitutional questions in there. Then comes TB. So TB might present with a cough, fevers. Now you ask the patient if they've had any weight loss or if they've had any previous TB drug therapy. Because in patients who've had previous TB drug therapy, this could be a reoccurrence or resurgence of the previous TB infection that wasn't cleared of. Now comes asthma. Asthma presents with shortness of breath, with cough. So to safely rule out asthma, and ask the patient for any other manifestations of an allergy. A lot of the time, asthmatic patients also have skin manifestations of allergy. So you might get the urticaria or the hives, which is very itchy skin. You might get a patient who loves to rub the eyes. For those of you who have allergies, these are some of the things you might experience. And then comes now orthopnea and PND. So of course, you're not going to ask the patient, do you have orthopnea or have you experienced orthopnea? So you're going to break it down and ask the patient, do they have any difficulty in breathing when lying flat? You're going to ask the patient, do they have any difficulty? Do they wake up abruptly in the middle of the night gasping for air? PND. They tell you they don't have any of this, then you can safely assume they don't have heart failure because this also falls under the Framingham criteria, and these are major points in the major points in the Framingham criteria. There's also the minor. There's a major and there's a minor Framingham criteria, which is used to diagnose heart failure. So please also go look up on that. I don't know, maybe Sean has touched on that in CVS. So that's what we use to diagnose. So we need, I think, 3 majors, 1 major, and maybe 3 minors, something like that. Also, this patient is RVD negative. It's important because, the patient might be immunocompromised and then these might be opportunistic infections. So to finish off the HPI, once you've done systemic analysis of the symptoms, you've done important positives or the risk factors, physiological factors, you've ruled out important negatives, you've done complications. In this case, the illness is too short to have any complications. But if it's more of a chronic illness, then it's like sickle cell, they have a few complications. You have to bring that out in your HPI. And then we've also, touched on medical contact, what's been done to the patient since. And then this last part captures that for us very nicely. Since arrival, the patient has been put on supplementary oxygen to ease with the shortness of breath, has had blood samples taken, has had a chest x-ray done, has received antipyretics and antibiotics. So the patient currently is relatively well and is awaiting results. Also make a small comment on how the patient's current well-being. So for this next part onwards, from the general exam onwards, David will be taking us through. David.
Hello, everyone. I hope you're doing well. So my part is to take you through the gen exam, the systemic, as well as investigations and management. There will also be a short question just for you guys to refresh your memory on what pneumonia is. So I have a headache, so I'm currently, I'll just be brief with this. So when we're doing a gen exam, apart from doing we'll do the jackals, and then we'll also we'll also look at more. But then these are the findings that you'd usually expect in a general exam when you're investigating pneumonia. So you'd have cyanosis. Does anyone? Okay. Too many questions. I'd have asked if you know why there would be cyanosis in a patient with pneumonia, but I will ask you to read up on that. There'd also be tachypnea. This is because of the difficulty in breathing, so they'd have to inhale faster, more deeply they would have to breathe faster to compensate for the lack of breathing over there that's happening. They'd also have tachycardia. That is an increase in heart rate. Pyrexia. Pyrexia is just the fever. And jaundice, as you can see, there are two asterisks there, meaning that it's very, very, very rare. It's rare and an atypical finding. Not typical, but atypical. It can also be found in lung cancer. So I think we can move on. Okay, so here we'll just do the relevant systemic exam. So on inspection, you'll find that your patient is breathing a bit too heavily. So that means that they'll use the accessory muscles in breathing. The accessory muscles, the relevant systemic exam is called RESP, the respiratory exam. So in such a case, with your patient, they'll use accessory muscles in breathing. I don't know if you can type in the chat different accessory muscles used for breathing. Okay. And they are divided into two. There are some for inspiration and the others for expiration. Expiration, I'll just mention the biggest one, the diaphragm. The diaphragm is an accessory muscle in expiration. So the others, you can just tell me as we move along. Okay, so also on inspection, you'll find asymmetrical chest movements. Like the chest is expanding a bit more on this side than on the other side. On the lung affected, this is because the lung will inflate more on the unaffected side as opposed to the affected side, the side with the pneumonia. It won't enlarge as it should. So you'll see the chest moving a bit slantedly. Okay, so when you do inspection, because usually the exam happens in the same system as everything else, inspection, palpation, percussion, auscultation, you come to palpation. Now in palpation, just before you touch the patient, you ask them if they have any pain or tenderness. Okay, pain or tenderness before you touch them. It's always nice to do that. Even if you know that they have no pain, it's always nice to ask. It helps you gain bonus marks with both patient and also the consultant. If ever you find yourself in a scenario where you have to explain what you're doing to the console, it gives you bonus points. Okay, so I see someone's written it. Thank you. So there will be a reduced chest expansion, which will be a normal finding in someone with asymmetrical chest movements because it's not expanding the way it should. The chest is not expanding the way it should. There's one side that's expanding less than the other, giving rise to the asymmetrical chest movement that you can see on inspection. So palpation, when you're doing chest expansion, you're just confirming it. There would also be an increased tactile fremitus. Yeah. Oh, guy, my headache. Yeah. So when you do the nane thing, you'll find that the vibration is a bit higher than normal. Okay. Tactile fremitus is when you place your hand on the chest of the patient and you ask them to say nane 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 nane. That's tactile fremitus, and the reason why this happens is because there is consolidation, or rather solidification, in the lungs. Pneumonia can bring solidification. That is why a differential for pneumonia is usually like a tumor or something, because usually consolidation happens if you have pneumonia or a tumor. It's a common finding in patients with pneumonia or a tumor or any other consolidation, such as parapneumonic effusions. Yeah. And another thing to note is that in pneumonia, when you do a percussion, you'll find dullness. Like it will be dull because there's consolidation or solidification in the lungs. Stony dullness in this case if there's a pleural effusion accompanying it. Pleural effusion is normally characteristic. You'll find as if when you're percussing, you'll feel as if you're hitting bone. Actually, just try percussing on your bone. That's the exact same feeling you'll find in that's stony dullness. So when you feel something like it's not doing anything, that's stony dullness on your bone. Yeah, so on auscultation, there will be reduced breath sounds. I'm sure you know why. Those are explained. And also increased vocal fremitus. Now, increased vocal fremitus is when you're using your stethoscope and then placing it on the chest and then telling them to say nane nane. Usually in physics, we have this thing where we say sound travels fastest in solids, travels in the middle with liquids, and then travels slowest with air. So in such a case where we are using our physics knowledge, in what point would you tell, okay, if it's a solid, liquid, or gas, at what part would you say that it's louder? Where is sound loudest? Is it in solids, in liquids, in air? I'm waiting for someone to do that in the chat. Someone said air. Solids, okay. One more person. Thank you. I've seen most people have written solids. So so the sound travels faster in solids than in liquids, and faster in liquids than in gases. This is because the density of solids is usually very high as compared to liquids, as compared to gases. So when you place your stethoscope on the lung that has pneumonia, lobar pneumonia in fact, and you tell them to say nane nane, you will feel as if they're shouting. They're not shouting, but you feel as if they're shouting. That's why. So you say nane, they'll tell you nane nane, but in your stethoscope you'll hear nane nane. So it's a bit jarring for someone who's not done it before, because now you're like, this is my personal experience. When someone said nane nane and then I had nane nane, I was like, hey, my ears were ringing for a bit. So it's a very typical finding in pneumonia. Can we go on to the next? Okay, so when we do investigations, we start with labs, then microbiology, then we go to the imaging. And this is how they're actually arranged here. So there's labs, that is the CBC, complete blood count, where you'd find leukocytosis, and you do your inflammatory markers, which is the C-reactive protein, and then ESR. ESR is erythrocyte sedimentation rate, which would be increased because it's a sign of inflammation. And then you'd also do your arterial blood gases, where you'd find reduced arterial oxygen concentration. Then now we come to the microbiological side of it. You do your sputum culture, your blood culture, and usually your sputum and blood culture will show you the microorganism that is affecting the body. Now, for the COVID test, remember what we said about atypical pneumonia. Now, for atypical pneumonia, if all your organisms are not matching if what you're thinking is not matching any organism, whether typical or atypical, then you come to COVID. COVID can cause pneumonia. That's why you also do a COVID test. Yeah. Then for imaging, the gold standard in pneumonia, chest X-ray. And then you usually find consolidation. Remember what I said about consolidation before? So this now you're confirming what you felt in your systemic exam. So there's consolidation, especially the right middle lobe. Now, in scenarios where you have lobar pneumonia, the pneumonia it also has a preference, like the same way guys would like to live in Karen, Runda, and not live in Kibera. The pneumonia would also want to live in the middle lobe. So it's usually around the right middle lobe, in fact. Okay, so I guess we can move to the next. Oh yeah, something else I forgot to mention. In your investigations, another thing you'd find in your X-ray findings is there would be translucent bronchi. You'd also have, they usually say air bronchograms. So there's appearance of a translucent bronchi inside the opaque areas. The opaque areas are where the consolidation is. Yeah, I think now I can move. Management, yes. So there's a scale we use to identify whether this patient requires to be in either inpatient or outpatient, or whether they require to be in the ICU. We call it CARB 65, as highlighted there in the white, CURB 65. Okay, so we usually do this in order to find out whether they need to be hospitalized, and each patient is assessed individually. And the clinical judgment is usually like the main basis. So that's why you'll find confusion, urea, respiratory, blood pressure, and then the age. So let's go on. So confusion comes about if your patient appears disoriented or has loss of consciousness or just impaired consciousness. Then we look at the serum urea. The serum urea should be, if it's greater than 7 millimoles per liter, or your blood urea nitrogen, your BUN, is greater than 20 milligrams per deciliter, then yeah, it's a bit tricky. It's looking bad. Then if your respiratory is high, and I mean high, like 30 breaths per minute, that's a danger sign. Blood pressure, if your systolic is either less than or equal to 90 millimeters of mercury, or your diastolic BP is less than or equal to 60 millimeters of mercury, then that's a danger sign. And then if your patient is has an age greater than 65 years, because that's already a dangerous sign. So each of these criteria are used as one. Each finding is one score. So confusion, 1 score; urea, 1 score; respirate, 1 score; blood pressure, 1 score; 65, 1 score. So the thing is 0 to 5. 0 meaning that nothing is up, 5 meaning very, very, very dangerous. So if your patient has a respirate that's high, okay, fine, that's manageable. That's outpatient because it's just one finding. But if they have, let's say, respirate and blood pressure, just like that, they have to be admitted into hospital. Then we move on. If your patient now has an age of 65 or older, in addition to what we just covered, ICU, that's immediate ICU. If they present with the same signs of pneumonia and they fit this criteria, ICU. Okay. I think another point to mention is that if serum urea is not really available, is not readily available, then you can do the carb without the U, the carb 65 without the U. And in that case, the CRB score of 0 means that the patient is treated as an outpatient. Yeah, as an outpatient. And if the CRB score is greater than 1, then hospitalization is recommended. Okay. So let's move on to the drugs that you use for management. This is an empiric antibiotic therapy for namely community-acquired pneumonia and the like. So usually we use amoxicillin or doxycycline. And we also do azithromycin and clarithromycin. And also we use ceftriaxone. Now, can anyone tell me the classes of drugs in, what's a ceftriaxone? What's the class of, what's the drug class in that one? Cephalosporin. Which generation of cephalosporin? Oh, yes, someone, kuna mtu ameandika hapo. So third, yeah, it's cephalosporin, and in specific, third generation. Okay, so azithromycin, I'm sure you know this, but it's a macrolide. I would normally ask you to give me mechanisms of action, but kichwa inauma, so acha tu. And amoxicillin is a beta-lactam. Okay, so it's aminopenicillin. Okay, so let's move on to the next slide. Now this is why I test if you guys have read or understood what pneumonia is, and I will ask someone to read the presentation for us. More the patient scenario, that is. Mustafa, hi. Hello.
Can you hear me?
Yes, now we can hear you. Could you read for us the patient scenario?
Okay. Mr. Kamau, a 65-year-old male living in Limuru, presents to the emergency department with a 5-day history of worsening shortness of breath, fever, and cough. He reports that his symptoms started with a mild cough and fatigue, but have progressively worsened over the past 3 days. He has also experienced chest tightness and wheezing, especially at night. Mr. Kamau has a history of hypertension, hyperlipidemia, and chronic obstructive pulmonary disease, COPD. He's a current smoker with a 40-pack year history. He has not traveled recently and has not been exposed to anyone with similar symptoms. Should I continue?
No, that one's fine. Now from there, I want you guys, there are 5 questions here, which is very important to test whether you've understood it or not. So I will ask people here who can answer them. Like, I'll leave it open to you. Whoever answers or types in the chat, I have no issues there. So the first question is mainly about the chief complaint and HPI. So what are the key features of Mr. Kamau's history that suggest a diagnosis of a respiratory illness? And what do you think are the potential causes of his symptoms? Anyone?
Shortness of breath is the first one, and the second one is a cough. They indicate that it's a respiratory illness, and the potential causes, I think potential causes might be TB, pneumonia, Yeah, I think mostly those two. SOB, cough, and a wheeze. Asthma because of the wheeze, yeah. Yeah, I think that's it for me.
Okay, so there's something you mentioned here. You mentioned that it could be TB. Could you explain why? Like when you're doing it, can you explain where in your history can that be found?
Just the shortness of breath and maybe the cough, but the history is saying that it's only 5 days. It doesn't indicate that it's a chronic cough. So I'd eliminate TB because of that.
Okay, yes, thank you. Thank you. What else can you? I had asthma because of the wheeze. Very true. What could have identified it as an asthma disease like PAP, like hiyo yenye unasema, as in if it's what could have told you that this is an asthma case direct?
Like maybe if the patient usually has itchy eyes, and maybe a family history, yeah, a family history, and maybe the itchy eyes. I'm not sure though.
I just want you to focus on the wheeze, just the wheeze. Like what can tell you? Wheeze and cough. What can tell you that this is asthma? We covered this in introduction to pneumonia, to resp history. Like,
Not sure.
The fact that he experiences, especially at night.
yes, especially at night. So in asthma wheeze occurs at night, and the cough also occurs at night and early mornings. That's typical of asthma. There was also something you mentioned. Which other differential did you give? Apart from pneumonia,
Pneumonia, asthma, and TB.
And you ruled out TB because it's not chronic. This one's an acute thing. Then you said asthma can be a reason because of the wheeze, especially at night. Then if you have to quantify cough, could have been at that same timing. Okay, so let's go to and also there are the key features that can tell you it's a resp case. Apart from the cough, the shortness of breath, there would also be chest tightness, there would be wheezing. That's very true. Okay, so what are the typical clinical signs that you'd look for in physical exam? This is both general exam and systemic. Which one would tell you that this is a respiratory?
For general, I think noticing that the patient is using accessory muscles of, yeah.
Go on.
For pneumonia, cyanosis, maybe it also have an increased respiratory rate. Yeah, that's what I can think of in general exam.
Okay.
Oh, and if
Thank
it's
you.
asthma, you'll notice skin manifestations, maybe the rashes for eczema, maybe.
Okay. What about systemic? What do you find on inspection, palpation, percussion, or auscultation? What can you find? Once again, open to everyone here.
Okay, for inspection, you'll notice reduced chest expansion. For palpation, maybe for pneumonia, as we learned today, stony dullness. Then auscultation, there'll be increased vocal fremitus, there'll be bronchial sounds at the peripheral lung fields. yeah, that's all I can think at the top of my head.
Thank you. So now I know that someone's read, that all of you have read. So can we move on? Oh, yeah, there was potential differential diagnosis, but these ones you've already covered when you're telling me that could be asthma, pneumonia, TB. I think we can move on to the next slide. So etiological factors. Now, potential causative factors of Mr. Kamau's symptoms, and how would you rank them in terms of likelihood? Like, what do you think? What do you think could have caused this? In such a case, I would like you to give me the causative pathogen or the reason why, and also a few risk factors that you can mention.
I can go with the strep pneumo as the
Strep
causative
pneumo.
agent
Okay.
because it is a common cause of community-acquired pneumonia.
Mm-hmm.
Yes,
So we're assuming this is pneumonia then, yeah?
yes.
What other causative agents are you most likely to have if it was okay? There were a few pathogens mentioned. Apart from strep, what else do you think could have caused it? And if we're thinking it's a very typical cause of pneumonia. If we're thinking typical.
Typical.
Yeah.
Haemophilus influenza.
Yes, Haemophilus influenza. Okay, that's a nice pathogen. Apart from that, there's also Staph aureus, there's Klebsiella pneumoniae. Yeah, I've seen someone writing Staph aureus. Okay, and risk factors. Someone's mentioned already the elderly and the immunocompromised. Yes, very true. What else? What else is likely to give you pneumonia? Savimbi mentioned it when he was dissing bachelors, of which I am. So, when he was dissing bachelors. What else? Yes, crowding. Yes. Nice. Yeah, that's why there was a segment asking what COPD is. What's whether they have a history of COPD. That's why it was there. Nice. So investigations. Just tell me which one. Just tell me what you do. I think from there, nothing's really. From there, E, F, and G are not really part of your level, but you can just tell me what's the gold standard for imaging as well. So investigations, you'll just tell me what investigations there are, and then we can stop on management. Just tell, yeah, you can stop there. Okay, what kind of labs?
Okay, we mentioned the markers of inflammation, that's raised ESR and CRP.
Yes.
There'd also be the arterial blood gas, where we'll have reduced VO2. For labs, what else for labs?
Aye. You'd also normally in labs you can start with complete blood count, then you go to the others, then you go in the others. Aye.
Oh yeah, for leukocytosis, I think.
Yeah. And then after labs, before imaging, there's something that you need to do. Nimeona watu wamesema imaging and they've given the gold standard, but in between imaging and labs, what else is done?
Blood culture.
Yes, blood culture, sputum culture, and then a COVID test. So you just mentioned that, you're fine. As for management, not people don't really tend to ask on that, which is why I'll just give you the drugs. It's usually azithromycin, amoxicillin, and then this other one, ceftriaxone. Those are usually the drugs that you give. Also, principles of management, you separate them into supportive and pharmacotherapy. Now, pharmacotherapy is the drugs. So supportive is what you can do aside from the drugs. Like how do you manage the guy? Basically, if he's on if his rest rate is high, if he has difficulty in breathing, you can ventilate him, you can put him on oxygen. And then the other stuff are beyond you now. So I think we can. Oh yeah, amixiclav is yes. Okay, now here's the thing about amoxiclav and amoxicillin. Now, amoxiclav is usually something that happens in complicated pneumonia. Like, how do I explain this? So, okay, this is an empiric antibiotic. So you give amoxiclav when you have combination therapy. Combination therapy meaning that you're giving amoxiclav if the patient has comorbidities or risk factors for resistant pathogens. Now that's when you give amoxiclav. Amoxicillin is just for healthy patients who just happened to have pneumonia for the first time. They have no comorbidities, they have no risk factors. They just happened to have had pneumonia. So amoxiclav is when it's a bit more serious in community acquired. Okay? Yeah. I think from there I'm done with my part. So yeah, thanks guys. I think subs, you can take it from here as I take Panadol for my head.
Right, thank you, David. Does anyone have any questions? The productive. So pneumonia being an acute infection of the lung parenchyma, mostly due to bacterial microbes, the productive cough is usually purulent, so it has to take on a color, green or yellow. Although this isn't saying like there will never be an instance it can be white. Medicine, you never say never, you just say there's a very small possibility. Any other question? Okay, then I guess that's it. So thank you guys for attending. We can call it a night then.